Okay. Hi, everyone. Good morning. I'm Brittany. I'm one of the second-year oncology fellows. I'm going to be speaking today about a new role using genomic profiling in the neoadjuvant setting for patients with hormone-positive breast cancer. Oh, how do I advance?
You should be able to
Oh, there
just
we go.
click, yeah.
A little bit of background on the use of neoadjuvant therapy for hormone-positive breast cancer. As we all know, hormone-positive breast cancer accounts for the majority of all new breast cancers in the US each year, making up about 66% of all new breast cancers. And the traditional treatment schema for early stage disease consists of surgery up front, followed by plus or minus adjuvant chemotherapy and plus or minus radiation therapy, and then adjuvant hormonal therapy for 5 to 10 years. And then we typically monitor for recurrence. The role of neoadjuvant therapy is typically reserved for high clinical risk patients. So those are patients who have clinically node positive tumors based on imaging or exam, or a tumor size of greater than or equal to 3 centimeters. The role of neoadjuvant therapy for hormone positive breast cancer typically consists of neoadjuvant chemotherapy, followed by surgery, and then evaluation for a pathologic complete response. And the clinical response rates can be between 50 to 90% to neoadjuvant chemotherapy, but the path CR rates tend to be on the lower side, between 2 to 27%, depending on which study you're reading. The ER status is conversely related to the efficacy of neoadjuvant chemotherapy. So the higher the hormone positivity, the lower the chance of a response to neoadjuvant chemo. And there have been meta-analyses that have looked at neoadjuvant therapy and whether that's equivalent to adjuvant therapy. And it does appear that neoadjuvant therapy is equivalent to adjuvant therapy in terms of safety, distant recurrence, and overall survival. However, there is a slightly increased risk of local regional recurrence, especially if surgery is excluded. And the benefits of neoadjuvant therapy include downstaging tumors to allow for breast conservation surgery, an in vivo analysis of the sensitivity or resistance to treatment, so you can see how they're responding at the time of surgery, and then to allow elderly or high-risk patients to avoid surgery altogether if they have a really great response to the neoadjuvant treatment. This is a meta-analysis that looked at neoadjuvant endocrine therapy compared to neoadjuvant chemotherapy for hormone-positive breast cancer. And 20 studies met the inclusion criteria, which included 3,490 patients. And in terms of clinical response rate, radiologic response rate, path CR, and breast conservation rates, they were similar between neoadjuvant endocrine therapy and neoadjuvant chemotherapy. So there was no statistically significant difference among all those parameters. However, they did see a lower toxicity with neoadjuvant endocrine therapy. When we look at what type of neoadjuvant endocrine therapy would be preferred, this meta-analysis also looked at aromatase inhibitors versus tamoxifen, and it favored the aromatase inhibitors in terms of clinical response rate, radiologic response, and breast conservation surgery rates. And the odds ratios are written here, and those three were all statistically significant. So the conclusion of this meta-analysis was that neoadjuvant endocrine therapy is associated with similar response to neoadjuvant chemotherapy, but with significantly lower toxicity. And when choosing a type of neoadjuvant endocrine therapy, we prefer an aromatase inhibitor to tamoxifen in that setting. Now I wanted to touch on genomic profiling in the neoadjuvant setting. So I'm sure most of you have heard of these genomic assays that we use to help predict the risk of recurrence and utility of chemotherapy for early stage hormone positive breast cancers. And these have all been validated in the adjuvant setting. The Oncotype DX is a 21 gene signature. The Mammaprint is a 70 gene signature, which has been validated for node positive patients up to 3 nodes. And then Blueprint and PAM50 are 2 additional signatures. And these may be useful to predict who may have a good response to neoadjuvant endocrine therapy in addition to their utility in the adjuvant setting. The MammaPrint was first validated in the MIND-ACT trial, and the MammaPrint is reported as a high or low genomic risk. It's binary as opposed to the Oncotype, which is on a continuum. And this study looked at 6,700 women who could have up to 3 positive nodes, and patients who had discordance between their clinical risk and their genomic risk were randomized to receiving chemotherapy or no chemotherapy. And what they found was that patients who had high clinical risk but low genomic risk had excellent 5-year metastasis-free survival without chemotherapy of 94.7%. And this met their non-inferiority endpoint, which was set at 92%. So this shows that in that group with high clinical risk but low genomic risk, they can be spared chemotherapy, and that's in the adjuvant setting. This is the NBRST trial that was published in 2017 that looked at chemosensitivity and endocrine sensitivity in clinically luminal hormone-positive breast cancer patients as predicted by molecular subtyping. So patients had MammaPrints done, and then they either received neoadjuvant chemotherapy or neoadjuvant endocrine therapy per physician discretion. And so you can see here in the table of the pretreatment clinical characteristics that these were 2 very different groups. The patients who received neoadjuvant chemotherapy tended to be 20 years younger. There were more patients who were pre or perimenopausal. They had higher rates of being clinically lymph node positive, and they were of higher grade, and they also had slightly higher rates of having high risk MammaPrints. So this was the group of patients that the physicians were more comfortable using chemotherapy in. And then the neoadjuvant endocrine therapy group tended to be older, more postmenopausal, less lymph node positivity, lower grade, et cetera. When they looked at path CR rates to neoadjuvant chemotherapy, overall that was 11%, but MammaPrint high genomic risk patients had a greater likelihood of having a path CR to chemotherapy of 13% compared to 2%. And that's just what's shown here. They also found that MammaPrint low and high patients had similar clinical response rates to neoadjuvant endocrine therapy. So both groups had about a 68% chance of responding to neoadjuvant endocrine therapy in terms of a partial or complete response. And despite low path CR rates, MammaPrint low patients did respond to neoadjuvant endocrine therapy, just as well as the MammaPrint high patients. And there were actually higher rates of breast conservation surgery with neoadjuvant endocrine therapy. But again, these were different populations that were receiving the 2 treatments. This is a study that was actually looking at oncotypes to predict response to neoadjuvant endocrine therapy. And these patients had oncotypes done upfront, and then they received 24 weeks of neoadjuvant exemestane and looked at the clinical response rates and rates of breast conservation surgery as their outcomes. So you can see here that among low recurrence score patients, they had a 60% clinical response rate to the neoadjuvant endocrine therapy, as opposed to the high recurrence score patients who only had a 20% response rate. So you could see a big difference in the low genomic risk patients responding to the neoadjuvant endocrine therapy. And the low recurrence score patients also had higher rates of breast conservation surgery compared to the high recurrence score patients. So I wanted to talk a little bit about a clinical trial that I'm working on with Dr. Tiersten and Dr. Schmidt. This is a phase 2 randomized feasibility trial at Mount Sinai using genomic profiling with MammaPrint to guide neoadjuvant therapy for patients with early stage hormone positive, HER2 negative breast cancer. And it's a flex sub-study, which I'll talk about on the next slide. Patients who can be included are adult patients with previously untreated hormone positive, HER2 negative early stage breast cancer, either pre or postmenopausal. They have to have ER or PR greater than 15% based on immunohistochemistry, and high clinical risk, so tumors that are greater than or equal to 3 centimeters or clinically lymph node positive. These patients will undergo MammaPrint testing, and then patients who have high genomic risk will receive standard of care therapy, which is basically neoadjuvant chemotherapy. And patients who have low genomic risk will be randomized to either neoadjuvant endocrine therapy with an aromatase inhibitor for 6 months, or neoadjuvant chemotherapy with either dose-dense ACT versus TC. And that's based on physician discretion. And then these patients will all go to surgery. During the neoadjuvant treatment period, we'll monitor with breast ultrasounds every 6 to 8 weeks and clinical breast exams, including caliper measurements, and then we'll evaluate for path CR at the time of surgery. The FLEX study is a large adaptable registry database that is run through Agendia, and they provide full transcriptome readout information, and the goal is to inform future breast cancer research and other targeted therapies by exploring the genome. And basically any patient who has a MammaPrint sent can be included in this adaptable registry database, and then we'll have additional genomic information read out. And the nice thing is that if you participate as a sub-study within the greater FLEX study, you have access to the entire database to do any other projects. So that's a nice benefit. The primary objectives of this study are feasibility of using MammaPrint to risk stratify patients in the neoadjuvant setting, as measured by recruitment rate, adherence to treatment group, and completeness of data collection. So this is really a pilot study just to see how feasible this is, and then would need to be followed by a larger study. The secondary objectives are efficacy of neoadjuvant endocrine therapy versus neoadjuvant chemotherapy in low-risk MammaPrint patients, as measured by clinical response rate and conversion from mastectomy to breast conservation therapy. Our exploratory objectives include change in Ki67, change in ER and PR expression, and rates of path CR. And our correlatives will be looking at next generation sequencing to detect resistance mutations to endocrine therapy, and the whole transcriptome sequencing provided as part of the FLEX protocol. So in conclusion, patients with early stage hormone positive breast cancer may be spared chemotherapy using genomic profiling in the adjuvant setting. Neoadjuvant endocrine therapy appears to have equal efficacy to neoadjuvant chemotherapy in hormone positive breast cancer patients. And we know multi-gene prognostic scores can risk stratify patients by genomic risk and identify patients who can be treated with neoadjuvant endocrine therapy and spared the risks and toxicity of neoadjuvant chemotherapy. And this is really the basis for the clinical trial that we're developing to address the feasibility of using MammaPrint, one of these genomic signatures, to risk stratify patients with hormone positive early stage breast cancer and evaluate the response to neoadjuvant endocrine therapy versus neoadjuvant chemotherapy. I want to say thank you to Dr. Tiersten, who's been my mentor now for over 5 years, Dr. Schmidt, who has been helping out a lot from the surgical side of planning this trial, William Audet from Agendia, Michelle Nezolowski, who's our clinical research coordinator, our biostatisticians, Erin and Meng, Dr. Malone and Dr. Kozik for their guidance, and of course my co-fellows. And no fellowship talk is complete without pictures of the baby that you had during fellowship. So my little one just turned 1. Thank you.
Brittany, that was terrific, and all the slides were wonderful, but the last one was my favorite.
Thank you.
So she's beautiful. Question, a more sort of holistic question. It seems like breast cancer, like many other solid tumors that are managed in a multidisciplinary fashion, we're continuing to refine our therapy based on genetic profiles, and we're trying to de-escalate therapy. I think that's certainly true with systemic preoperative or postoperative chemotherapy for breast cancer survivors. Are we also starting to look at endpoints within our system? I know there's a movement afoot to even see if we can identify patients who will not need surgery, who can be managed non-operatively, and who might not need whole breast radiation, but just sort of consolidative radiation therapy, partial breast radiation.
So that's not really built into this protocol, but it's definitely something that we discuss a lot at the breast tumor board for patients who are not good surgical candidates. And I think we're giving a lot more neoadjuvant therapy now. And so definitely older patients with a lot of comorbidities, if they have a great response to neoadjuvant therapy, they may be spared surgery altogether. So that's definitely something that is being done clinically.
This is Amy Tierston. Just to add that there were a couple of abstracts presented at, I believe it was San Antonio last year, looking at doing away with surgery in patients who had, a clinical complete response, not hormone receptor positive patients, but I believe it was triple negative or HER2 positive patients where we had to see a really high rate of clinical CRs. And, taking biopsies, and if they're negative, looking to see whether that correlates with past CR surgically. And they were both negative trials in that they did not suggest that you could not do surgery.
Okay.
Disappointingly.
I hear you. And do you, just one last question, and then Dr. Gabrielov has a question. Do you, given the possibility of a major response or a clinical complete response, do you routinely have markers placed so that people know where to direct their beams or their scalpels?
Markers are always placed at the time of core biopsy.
Yeah,
Yes.
during biopsy.
All right.
Yeah.
Sorry, I fell off the breast oncology merry-go. Thank you.
So Brittany, really very nice presentation. Very great clarity of thinking. I had two questions. One is, in your exploratory aim, are you planning to look at the burden of mutation, or what is your cutoff for a positive mutation, since these are usually reported as percents? That's the first question. And the second question is, as with any clinical trial, even though this is a feasibility study, as the consort system requires, how have you decided to handle missing data? That will always inform conclusions that you can reach.
Yeah, so let me answer the second question first. And I think that we're planning to only include patients who go to who go to surgery. So if the patient doesn't go to surgery, then we would need to replace that patient. That's what we had spoken about with our biostatistician. And in terms of the first question, when we're looking at the next generation sequencing to detect the resistance mutations, we don't expect those to be present at baseline. We only expect those to develop after treatment with the aromatase inhibitors. So we'll be measuring that at the, after they've had 6 months of treatment with the endocrine therapy. And
right,
I don't
but
know
you'll still need to decide what you call a positive mutation and something about the allele burden. You'll need to, again, I realize this is a secondary endpoint, but it's something that perhaps you should discuss with the biostatistician or people who do these kinds of genetic analyses, because you'll need to include that in your methods.
Yes,
so something
definitely.
to think about.
Thank you so much.
And the missing data that you mentioned, that's very helpful in terms of what you're going to do and replace. But you may want to think again with your biostatistician how you handle any missing data, any data points, whether how they will be handled. So if you're doing repeated measures of any parameter and that data is missing, how are you going to handle it so that when you do an analysis, be it a primary or a secondary analysis, you can control for potential introduction of bias. So that's something you might want to think about in more detail, depending on whether you've already discussed that or not.
Yes, we'll discuss that in more detail with our biostatistician. Thank you.
I have to jump in. We have another presentation, so unfortunately we can't. This is a very good conversation, but unfortunately, Dr. Bala has a presentation. So,
okay.
Unfortunately, Dr. Bala has a presentation. Just cut this conversation short.
Okay, thank you.
Thank you. Sheena, thanks for waiting, and we're gonna have to go a little bit over time possibly. So go ahead.
All right, can you hear me?
Yes.
Okay. All right, so I'm Sheena. I'm one of the second-year fellows, and for my research and progress presentation today, I'm going to be talking about two studies I'm working on. One is a thoracic oncology trial, and one is a COVID and cancer outcomes study. So to start with the thoracic oncology trial, which is looking at rigosertib and nivolumab in patients with metastatic lung adeno with KRAS mutation. So adenocarcinoma accounts for 40% of lung cancer. And over the last decade, many genetic alterations have been identified in lung adenocarcinoma, with KRAS being the most common and accounting for about 25% of lung adeno in Western countries. The KRAS mutation is associated with poor prognosis and decreased response to platinum-based chemotherapy. To briefly review the pathway, so KRAS is a GTP binding protein that links receptor tyrosine kinase activation to intercellular signaling. Mutation of KRAS favors the GTP-bound active state and constitutive activation of downstream pathways such as RAF, MEK, ERK, and PI3K, AKT. As of now, there are no approved therapies targeting this mutation. This is a busy slide, but the main point I want to make is how many strategies have been tried in the past 3 decades to target KRAS, either through indirectly binding KRAS effector pathways or more recently directly through allele-specific RAS inhibitors. And as you can see for these indirect approaches, they haven't been very successful and have led to either terminated clinical trials or these agents are now being used for different purposes. And there are many reasons why targeting KRAS has been challenging. There's a great deal of genomic heterogeneity and clinical variability among KRAS mutations. Due to many KRAS mutation subtypes, I've listed a few here. G12C, G12V, and G12D are the most common. We also have co-occurring genetic mutations with TP53 and STK11. There's also a lack of a well-defined druggable pocket on the KRAS surface, which has historically been difficult to target. That being said, in the last couple of years, we've actually had a lot of exciting movement in KRAS. Much of this progress has been in mutant-specific KRAS inhibitors, which have overcome this undruggable pocket I mentioned. So many of you have probably heard of AMG 510, which is a KRAS G12C inhibitor. Another promising strategy is targeting these downstream effector pathways as previously attempted, but now combining these agents with either RAS direct inhibitors or immunotherapy. So for this talk, I'm going to focus more specifically on this combination approach of using immunotherapy with these agents. So as many of you know, checkpoint inhibitors have become standard of care in metastatic non-small cell lung cancer. And I previously mentioned that KRAS mutated tumors are less likely to respond to platinum-based chemo, but there's reason to believe that KRAS mutated tumors would respond to immunotherapy. KRAS mutated tumors are often associated with smoking and TP53, which we know are risk factors for genomic instability and tumor mutation burden. The efficacy of checkpoint inhibitors has also been demonstrated in prior studies. So in the post hoc analysis of Checkmate 057, which looked at nivolumab and docetaxel in the second line setting, patients with KRAS mutated tumors were actually more likely to benefit from nivolumab than those with wild type KRAS in terms of overall survival. Additionally, there's retrospective data out of France that shows that the efficacy of checkpoint inhibitors was similar in the KRAS mutant population and the KRAS wild type population. And in fact, as you can see in this graph, among KRAS mutated tumors, the efficacy of checkpoint inhibitors is actually higher with those with higher PD-L1 expression, though the authors found that this wasn't statistically significant. That being said, there's also evidence that mutated KRAS may decrease the anti-tumor immune response. And that is for several reasons. So first, RAS signaling can upregulate tumor PD-L1 expression. And this is because MEK signaling, which is downstream of KRAS, typically negatively inhibits TTP, typically inhibits TTP, which negatively inhibits PD-L1 expression. And so when you get abnormal KRAS expression, you can get an increased PD-L1 expression. Aberrant KRAS expression also results in induction of many immunoregulatory cytokines and chemokines. And third, we see that in KRAS mutations, they're correlated with downregulation of HLA class 1. So now there's interest in using this combination approach and inhibiting these downstream effector pathways to enhance the effect of immunotherapy. So in this trial, to inhibit the downstream KRAS pathways, we're using rigosertib, which is a small molecule RAS mimetic that binds to RAS binding domains of multiple RAS effectors. It's currently in ongoing clinical trials for MDS, run here by Dr. Silverman and Dr. Navada. And it's an overall well-tolerated drug with a unique side effect profile, primarily fatigue and urinary symptoms. In lung cancer, there are preclinical studies that rigosertib can inhibit tumor growth in xenograft mouse models of lung cancer. And this is associated with a downregulation of MAPK and PI3K signaling. In PDX mouse models, rigosertib has effects as both monotherapy and synergistically with a Chinese PD-1 checkpoint inhibitor. And so based on this combination of rigosertib and PD-1 checkpoint inhibitor seems to be a possibility in metastatic KRAS lung adeno, given that both agents have efficacy in lung cancer through different but potentially synergistic mechanisms and a side effect profile that doesn't overlap. So this is our study schema. So we're including patients with ECOG 0 to 2 who have metastatic lung adeno with KRAS mutation, who've progressed on standard of care checkpoint inhibitor monotherapy or in combination with platinum-based chemo. The main exclusion criteria are EGFR mutation and ALK translocation, active autoimmune disease or steroids more than 10 milligrams per day, and untreated CNS metastases. The study starts with a dose escalation phase to determine the maximum tolerated dose of rigosertib, which would be given at a 28-day cycle, and nivolumab would be given at the standard dose every 2 weeks. Given that we already have initial safety data in rigosertib in the MDS population, we're using an accelerated titration design with single patient cohorts. And if a grade 2 toxicity is experienced during this accelerated titration design, then a 3x3 design would be implemented. Once the MTD is determined, 12 additional patients would be enrolled at this dose and would undergo 6 cycles of rigosertib and nivolumab to determine these secondary objectives, including overall response rate, progression-free survival, and overall survival. Additionally, we're planning for correlative studies to explore genomic and immune changes before and after the rigosertib and nivolumab combination. So currently for this trial, we were delayed due to COVID, but we actually consented our first patient who's getting her pre-treatment biopsy today, and she is hopefully going to be starting treatment next week. So I wanted to switch gears a little bit from there and talk about a COVID-19 and cancer outcome study that I've been working on as well. So as many of you know, cancer care delivery during COVID has been very challenging, and we've all had to weigh the risks of harm from cancer versus harm from COVID-19. There's been a wide impact on cancer diagnosis, treatment, and surveillance. And these effects on individual and society level cancer-related outcomes really need to be investigated. And so the overall aim of this study was to define the impact of COVID-19 on cancer care delivery to ultimately help us inform future care and develop the appropriate mitigation strategies. This is a multi-center cohort study with Mount Sinai and Dana-Farber Cancer Institute. Our primary objectives are to examine the impact of COVID on clinical decision-making and clinical trial-related care as measured by the number of outpatient visits, number of telehealth visits, and changes in systemic treatment regimens. And our secondary objective is to define the outcome of patients in the cohort who developed COVID-19. So we identified patients with solid and heme malignancies who were seen in outpatient clinics at Mount Sinai and Dana-Farber from March 2nd to March 6th, which was our index week. We collected patient cancer and treatment-related variables at 3 time points, the first being 3 months before the index week, which was our baseline period, then at 3-month follow-up and at 6-month follow-up. We're capturing variables including number of office visits and televisits, treatment delays, imaging and diagnostic procedure delays, any therapy changes, clinical trial enrollment, and then the development of COVID-19. So we initially identified 2,103 patients who were seen at or scheduled at our hemonc clinics, Uptown at Sinai, at West, Chelsea, Union Square, and Morningside. 597 were excluded because they were non-oncology cases, no-shows, or duplicates, making our final Sinai cohort at 1,506 patients. The Dana-Farber cohort primarily included GU, thoracic, and head and neck patients, and currently is at 881. So I wanted to just share some baseline data with you about our cohort. So as you can see on this right column, our total cohort based on those numbers I gave you is 2,387. The mean age is 64. The Sinai cohort has a female predominance given our large number of breast patients, and the Dana-Farber cohort has a large predominance of male patients given their prostate cancer patients. We have 13% Black in our cohort and 12% Hispanic, and these minorities were primarily represented in the Sinai cohort. 80% of our patients had at least one solid tumor, with prostate, breast, and lung being the most common. And about 20% of our patients had a heme malignancy with lymphoma, with myeloma, and then lymphoma being the most common. 14% of our patients had a second cancer. Of those with a solid tumor, 40% were metastatic and 16 to 17% were localized or locally advanced. Of those with a heme malignancy, 40% were active and 28% were stable, which is, we considered no major treatment changes in the last 6 months. 61% of our patients were on any treatment during the index week, with chemotherapy being the most common at 21%, and then 11 to 18% being on other forms of therapy, including checkpoint inhibitor, targeted therapy, and hormone therapy. 8% of our patients were new cases during the index week, with over half of these patients being offered systemic therapy. And 13% of our patients were enrolled in a clinical trial during the baseline period. So we're currently collecting our 3-month follow-up data, and we're really getting a chance to see how cancer care for this cohort has been affected due to COVID. And we're on target to finish this data collection by mid-July. So before I end my talk, I just want to thank a lot of people who've helped me along the way. For my thoracic oncology trial, Dr. Velaswamy, Dr. Reddy, who did the initial work on rigosertib, and the entire thoracic oncology and clinical trials team. For CCOS, Dr. Doroshow, Dr. Galsky, our collaborators at Dana-Farber, and many fellows, residents, and CRCs who have been really amazing in helping us with data collection. And then, of course, Dr. Malone, Dr. Kozik, and my co-fellows, who have been incredibly supportive over the last couple months. I'm happy to take any questions if there are any.
That's really great, Sheena. I'm just a little concerned about the imbalance between the two centers. Do you want to just address that? I mean, they're just such different populations that you've enrolled.
Yeah, for sure. I think we're doing our best with our data collection to account for just changes that may be seen based on the populations to begin with in terms of baseline characteristics, but then also treatment changes. Are there any more specific concerns?
Well, William, I can also speak a little bit to this. This started as a collaboration. This is Debbie Doroshow. This started as a collaboration with Tony Schwery,
Mhm.
and was really very much focused in GU, and they were able to reach out to colleagues in head and neck and thoracic to try to diversify, but they just don't have the manpower to do every patient seen at the Farber during that index week, unfortunately. So that's why we're a bit unbalanced when it comes to tumor types.
Yeah, I mean, you might want to, when you do the analysis, look at the comparable tumor types as a subset, just because the two groups are so different. You know, heme malignancies, it's a different selected population. So,
Right, definitely planning to do analyses within the group.
great.